Welcome everyone to another wonderful episode here, Just Podiatry. We've been following this young gentleman for for quite some time. How many months do you think? Approximately now? 6?
No, maybe
Not
2
even?
or 3.
2 or 3?
3.
3 months. We've been following him for about 3 months. It all started a little nothing. Am I correct?
A little cut.
A little cut. Just a tiny little cut. Patient is diabetic. Patient has severe vascular disease. It's kind of like that deadly duo, right? We've spoken about it before. So this patient, I've said, just like I've said before, no blood, no healing. It's very, very simple. We sent the patient to a good friend of mine recently. I guess it's unfortunate because he ended up at a hospital. In the hospital, he ended up in the wrong hospital. They tried to do some type of vascular intervention, and I believe that the vascular surgeons were not able to do what they should have done. In other words, not all vascular endovascular surgeons are created equal. The new, what I like to call the new age physicians, whether they're interventional radiologists, even cardiologists, even interventional vascular surgeons that have better training, that they can actually do magical work. In this particular scenario, they ended up in a hospital. I am not really sure what they did with the toe at the time. We spoke about it, sort of, you know, it was kind of like all hazy and gray. The vascular surgeon was not able to do anything. And it's a shame because you go into a hospital with the hopes that they have the right resources and the right people in the right places to get, the job done. So then they ended up coming here about a month ago, and I saw the patient. And then, just to be very clear, this is not my patient. One of the other doctors here sort of brought me into the case, and I said, listen, let's go and send this patient to a good friend of ours nearby. And he has tremendous training to, whether it's from the thigh region down to the foot or vice versa, it doesn't really matter. These I just want to be very, very, very clear with everyone. These endovascular surgeons, whether they're surgeons, interventional radiologists, anything that has to do with intervention, that they can accomplish a lot through a tiny, tiny, tiny little incision. They really do amazing work. Some are more competent than others. Some can actually do, they can actually open up more these vessels that are tiny. The big vessels are up here, and it's kind of like a tree. If you take a tree and you flip it around, the trunk is now at the top. It's the biggest vessel, and then you have the branches, which are smaller vessels, and then you have the leaves, which are the tiny, tiny little vessels. So these individuals can actually go all the way down to the smallest of vessels and try to open and provide more blood supply. And this is exactly what this physician did. So one little cut. Let's go now to the clinical presentation. So we have a patient who, from a little cut, ended up with this. So what's happened? The last time I saw him a month ago, he actually had the toe. Obviously, it's still there, but the girth of the toe looked kind of just like a normal toe. It was definitely on its way. There were a lot of skin changes. There was already gangrene in process. It was semi-wet, and there's different types of gangrene. You have dry gangrene, you have wet gangrene. Dry gangrene is okay, wet is not. There was malodor. There is no malodor today. And this particular doctor, this endovascular interventional endovascular surgeon, he recommended to the family members, said, listen, there's really not a whole lot to do here. Just let the toe mummify, basically shrivel up like a raisin, and it will fall off. And I respectfully agree. Very few times do I agree with decisions as such, where basically it's better just to let the body decide, I'm going to get rid of this and I'm going to keep this. So the body right now is going through that process. This is dry gangrene. It's basically the toe is non-viable. This is viable tissue. This is non-viable tissue. And just so everyone understands, I can move the toe, right? He has no pain. I want to be very clear with all the viewers. The patient has a little bit of an element of dementia. Am I correct? He's totally perfectly lucid, excellent. And even better, even when I do this, he has no pain. Which tells us that, obviously this is all non-viable tissue. The joint is right here, okay? I'll just kind of this is eventually going to come off. So, this is the bone there, right? Right, this is the bone there. And then let's take a look underneath here. I want to show everyone here. So this is a little bit more this is what I call kind of a little bit more moist, wet. This is going to eventually dry up. And then over here, you have the flexor tendon, right? You can actually see it. I don't know if you can get a good, I don't know if you can see it.
This is dark.
Well, what about there? That white, shiny, can you see it there? That's the flexor tendon. That's the one that flexes the toe down. And what's going to happen, the good news, I was just telling the family member, look, I want everyone to look down here. I'm sorry about that, bud. Right here, you see that? That red tissue, that means blood is getting to this area. So the toe will end up it happens extremely quickly. It's been a month and all of a sudden it's like, just like I told the family member, it's been 50, it's just kind of just deflating. And once it gets to that point, we're not really sure when it's going to happen. Possibility, they may find the toe on the floor. They may find the toe inside a sock, inside the shoe. The family member is well aware of this. I did tell the patient, the family member, that...
Are you okay? Are you falling off? Okay.
Yes. I know, I'm boring.
I didn't say no.
No, he got other issues.
I didn't say anything.
I did tell the family member that if they see that the toes, hanging by a thread, so to speak, just come, immediately, and we'll take care of that here. And then we can just, move and have a plan of attack, and then we can, discuss that in greater detail. The problem with going to the hospital, because I'm sure a lot of people are saying this patient needs to go to the hospital, right? No, the patient is better off staying out of the hospital. Being in the hospital can cause other issues, like what? Like respiratory tract, nosocomial infection, pneumonia, any other infection that he doesn't currently have. Going, and then someone would probably take him to the operating room. Then you're risking the patient going under anesthesia. That's another huge risk. And then after that, then possibly head into a skilled nursing facility, and that's another slippery slope. So, he's better off just, we as a unit, we're better off doing what we're doing right now, which is just sitting tight and keeping a very, very close eye on this toe, keeping it most importantly dry, right? Dry. We cannot wet this toe. If we wet it, it's going to go wet on us. Wet gangrene, smelly, malodorous. Right? We don't want Clostridium. It's one of the bacteria that really, really just will flare up. And this if this goes wet on us, it could put the organism at risk. It can affect him in respect to bacteria in the bloodstream, and we don't want that.
What about the side?
Excellent. We already spoke about that as well. So let's go to the side. So this is another big problem that we have. It's a small but yet a big problem. It's basically what we call an eschar, eschar. We're just gonna have to also sit tight and wait to see what the body decides. Hopefully, what usually happens, there's healing underneath, and it will start to contract until it basically just falls off.
Just the side there?
Yep. A lot of people, a lot of surgeons would say, "Oh, he just underwent a vascular intervention. There's enough blood supply. Let me have a pickup and a blade. Thank you very much." And they would carve that out. That's a no-no, because right underneath there is bone. So if you remove that piece of tissue, you're exposing the bone to the world, and then now we have another problem. Now we have bone infection. So we're using it to our advantage, and it's best to just leave everything as is. He has an element of macrovascular as well as microvascular disease. So make believe he has, even though I showed you guys a little bit of the red tissue here, he still has a significant amount of limited blood supply to the area. It's extremely limited. It's a trickle. So best thing to do with something like this is keep all the weight off of it, offload it. Doesn't matter how, pillows, foam blocks, foam, whatever it is, no weight, no pressure.
He has one of those boot things.
That's it. Even with those, sometimes even a little bit of pressure will not allow it to heal. So we definitely have to keep a really close eye on that as well. I will definitely keep everyone afloat on this patient's progress. I'd like to see him on a weekly basis at this point, even maybe if needed, maybe next Wednesday. Okay, even though today's Thursday, we'll say a week. If you see that it's really shriveling quickly and mummifying, just bring him in. Absolutely. Let's give it another look so everyone can see again. This is a great toe that has mummified, and we're just being very patient. It will eventually fall off, or we will just do just take it off here. Yep, all that.
And how should the wound care treat that?
Everything we keep dry.
Just with the Benadine?
Yep. In this particular case, even though betadine keeps everything dry, it is caustic. In other words, it's if you put it on healthy skin, it's not healthy. So it's very, very powerful. It does kill all bacteria, or most of all bacteria, and it keeps it dry. So we want a dry process. We don't want the wet process. Like always, www.justpodiatry.com, Instagram, Dr. Tojam, Just Podiatry, Facebook. I know this has been a little bit of a lengthier video. I hope that you guys have enjoyed it. More than anything, this is all about education, prevention, diabetes and vascular disease. We continue to talk about. It's very unfortunate. That combo is just, it's poison. And and I don't want anyone to take this the wrong way. I continue, and I will continue. I haven't said it in a long time. Diabetes is a type of cancer. Diabetes, there is no up. There's no getting better. Diabetes is only a straight line or down, right? It's either like this or like this. And that's where the education comes in. When individuals are diagnosed with diabetes, they have two choices. They can either grab it by the horns and embrace it and educate themselves on it and be able to
Stabilize.
Stay however long it takes in their entire life to stay on that straight line, or it will kill you. So I've said it before. I did get some resistance from some of the subscribers that it's not fair to call diabetes a cancer. It's an analogy. It's a type of cancer because it affects every single organ in the body if you don't take care of it. If you take care of it, super. If you don't, slowly but surely, it's all downhill. And the diabetes, did he ever smoke?
A long time ago.
A lot?
Probably.
Well, that's another contributory factor, smoking. But let's say I have a lot of patients who have diabetes, never smoked. And they have all of their arteries in their toes, lower extremities, are calcified as a result of what?
When he smoked, it's probably
I haven't
40 years.
smoked in over 40 years.
40 years, yeah. Put things into perspective. He smoked for 40?
No, he hasn't.
Oh, hasn't.
smoked
And how
for
long did he
40.
smoke for?
Hmm,
Another 40.
Yeah, probably.
Yeah,
No,
probably.
Maybe 30.
So putting things in perspective, I'm 41.
I'm 89.
And you're 89.
Yeah.
I could be your brother.
Huh?
Thank you for
I'm
watching. everyone.
89.
I have